So welcome officially to week 3. This is awesome. We're plugging right along. This week's lecture is Community Health Open. Excellent. I'll open the med surge too. I'll be sure to do that. So I'll make sure that everything's open for everybody. So with that being said, with the ATI, so this ATI is next week. So our class time at 1 o'clock, we do not have class. You will just log in and log into ATI, and we'll start your ATIs. And a little side note for that, y'all know that you can take your ATI whenever, right? So if you want to get med surge out of the way and you feel comfortable taking it, you don't have to wait till week 8. So I'm not sure if everyone's fully aware of that. I learned that last semester or the semester before when somebody asked to take it early, and yeah, one of the deans was like, yeah, if you want to take it, I'll give you the ID and the code, and you can go on to the website and schedule that if you feel comfortable taking it. So if anyone wants to do med surge early, let me know. Be happy to do that for you. A couple of housekeeping things. So let's see. ATI, 1 o'clock next week, no class. And then there's no class the week after that. We have our exam on campus. And for this group, it's 1:30 p.m. I'll let you know what room it is. I'll send that out as an announcement. I'm presuming, I should say, maybe 107 where our lectures are, but you never know. On that same note, exam 1 was compromised again. So somebody leaked some exam 1 stuff, so the traditional exam that we had last semester will not be the same exam 1 we have this semester because of compromisation of that. So please don't compromise the exam. Not only does it create havoc for everyone behind the scenes, it's just not the right thing to do, and it creates a lot of issues. If for this week, if you have not done your discussion initial post or your 2 replies, please go ahead and do that. We'll get those points for you up on board. And, all right, what? Sorry, I'm catching up on my chat here because it just, okay, never knew that. What? Yeah, ATIs. I'm sure that's from the ATI. What? All right, so, and we'll go over this week's assignment. The other thing is, let me share my screen so everyone can see. All right, put up chat, put you over there. Ooh, put me over there. All right, you should be able to see my screen, correct? I'm going to put up this Excel spreadsheets. Everybody see that? Everybody seeing it? Yeah, okay, cool. So the only reason I want to point this out is our on-campus weeks, lecture on campus, and this group is down here. It's weeks 1, 5, 9, 10, and 11. I got an email last night at like 9:30 at night going, so we're on campus tomorrow, and I just about hit the roof, ran to my computer, opened it up because I was like not ready to come on campus. So we are not. The next time we're on campus is week 5, and that is for the exam. Week 9 for the exam. Week 10 is a lecture, and then week 11 is for an exam. So I just want to make sure everybody's clear on that when our exam dates are and when we're actually on campus. The rest of them is going to be virtual. One thing I did, the exam reviews, I opened up exam 1 review. So that is in there for you. I have not changed it yet. If I can get time and carve out the time to re-record it, I will, and just change it out. It's the same content. It's just whether it's in a PowerPoint presentation versus just a format. It's all the exact same content. So that is open for you. Also with the live recordings, I will have lecture 3, which is today. I will upload 4, and then 5 will be uploaded also. 5 is not on the exam. The exam covers 1 through 4, so I'm not going to really upload that or make it visible until after the exam. There's no need to worry about extra material that you don't need to put in your noggin. All right, and the last thing I want to go over is our assignment this week. Assignment this week's a pamphlet, which is kind of cool. It's something that you may get tasked with, again, as a nurse. And those of you who've already started it, actually I think I've already graded this whole group. 2 came in today. But it's pretty cool. It's about myasthenia gravis. You're on a floor. The nurse manager says, there's a concern about the level of understanding about it. So please develop a pamphlet. And a pamphlet's just a 1-page thing. It's something that can be trifold or bifold. And just to make sure that you can, educate your patient on it. So the question came up is, do we need to cite it and reference it? Although it does not say it here in the instructions, I would like you to put your citations, or at least your reference page in there. It's always a good habit to add your references and citations because it adds legitimacy to it, 1, and professionalism to it, 2. You don't need to do in-text citations or anything like that. It's just you can put that in there, and the reference is for my edification to know that you did evidence-base it. But all you have to do is describe the process, list 2 community resources, and they can be whatever. They give you examples of nutrition, transportation, or psychosocial needs, but whatever you care to do. Medication administration, and the key thing is importance of timing of the medication delivery, because with myasthenia gravis, it is important for that. And signs and symptoms of myasthenic crisis. If you can make it easier for me, just type in myasthenic crisis over that. Just that helps me get my eye right to that part to make sure that you kind of hit that for the grading purposes. Again, word count doesn't matter. You can be as creative as you like or as plain as you like. Some people are just not that technologically advanced, so that's okay. I'm not going to hold that against you. So any questions about this week's assignment? If you do, pop it in the chat. If not, you can send me an email too. That's it. So this week's lecture is actually going to be a breath of fresh air for you. So I'm going to open that up here. Everybody see that? Should say module-free peripheral nervous system. Awesome. I'm going to shut off my video. Okay. All right, cool. So this week is our final week of neuro, which a lot of people will say, woohoo, no more neuro. But yeah, this is, and again, week 1 had a lot, it was really heavy. Neuro content. Week 2 was stroke and migraines, a little bit less. We did traumatic brain injuries in there. This is on peripheral nervous system. And again, we worry because these are some of the more rarer disease that we don't come into contact with every day. But the good thing is there's only 2 of them we need to discuss this week. 2 diseases. That is it. And we're going to add 2 more just to review that we already went over. Before we start that, I put this slide up because I thought it was neat. There was a massive study came out, and this was in the beginning of the year, January. 10 million military, and they found out that the link, the causative factor to multiple sclerosis is the Epstein-Barr virus. So that causes mono, the kissing disease, highly, highly contagious, and they figure that most people have been infected by their 20s, but that almost always is a delayed response to this particular virus. And again, when we know what the causative factor is, it can help us with treatments along the way. So I just thought that's pretty cool to come across that information. So again, first couple of slides, like every week, we'll just get everyone back on the same page. This is not anatomy and physiology. Don't worry about all this. So much as remembering is just kind of the refresh your memory on it. So the peripheral nervous system delivers sensory information, and it goes up to the central nervous system. And then the CNS sits there, processes it, and it carries out some sort of motor command back to the periphery. There's bundles of axons that are nerve fibers that carry the sensory and motor commands. We know that. And they come in the pair of spinal nerves. So there's 31 spinal nerves. They come off the spinal cord, and they actually correlate to those dermatomes that we looked at last week or the week prior that help us identify what's going to be the sensory motor function area. There's also 12 pairs that emerge from the brain. Those are our cranial nerves. They are actually part of the peripheral nervous system, but we kind of designate them as the cranial nerves because there's 12 of them that originate there. Now, there's 2 different divisions of the peripheral nervous system. There's the afferent, or the sensory division, and those are those sensory nerves. That brings information to the central nervous system to process it, and then it in turn goes down to the peripheral tissues or organs from those receptors. The receptors are actually called, they detect and respond to changes. The receptor organs, I mean, it's pretty convenient, that's what they do. And their eyes and ears is the organs, or their neurons or special tissue, like cells that can touch and detect heat, pressure, vibration, proprioception, all of that. Now we have the efferent division, and that's what carries out the motor command. So it's glands, it's muscles, it's adipose tissue, and those target organs that respond are called effectors, which is kind of nice. It mimics that efferent division. The efferent division has a somatic, which is a voluntary portion, and an automatic component, it's the autonomic nervous system. And those somatic system is skeletal muscle contractions, the primary thing we correlate with it. There's a brief bit of involuntary overlap, and that's your reflex arc. And we'll talk about that just quickly in the next slide. Our autonomic nervous system is our kind of visceral motor system. It's on autopilot. It's automatic regulation of smooth muscles like our cardiac tissue, glandular secretion, subconscious level. We don't sit there and go heartbeat, heartbeat, heartbeat. It beats on its own. Same with respiratory drive and, glandular secretions. We don't have our adenohypophysis sit there and, okay, you secrete this, you secrete that. It does it automatically. And that's further broken down into divisions. And we've heard of these before. We have our sympathetic division, our sympathetic nervous system. And I think sympa and stress, 2 S's. Sympa means stress. So that's fight or flight. That's heart rate goes up, blood pressure goes up, my pupils dilate, my bronchioles dilate to get more air in, pupils dilate to take in more peripheral vision. My oral secretions dry up so I don't aspirate. So all of that's taken into consideration. My GI tract slows down because I don't need to process food right now. I need energy to do something. And then there's the parasympathetic division. And with para, I think peace. When you're at peace, your heart rate slows down, your blood pressure slows down, goes down, your pupils constrict, your GI starts to move. Now it's time to digest some food. Going on that, we have that reflex arc. So the reflex arc is kind of a vestigial response that's built into us. It's a survival mechanism. Normally, we have our sensory detection. That's on the dorsal or the back end of the spinal cord. So you get these receptors. It goes in the back end. It climbs up to the brain. It says, oh, I sense that. And it travels down the ventral or the front portion of the spinal cord to some sort of effector, like a motor neuron. But when it senses danger, like heat, for example, you touch a hot stove, it completely bypasses that. Your hand is jerked back before you even process or feel the pain of that heat or that cold or that noxious stimuli. That's your body's innate system to do that. There's a term that comes into play, and we'll hear it later on in the lecture, but it's called ganglia. And ganglia is just a collection of sensory neurona, soma. So this busy picture, don't worry about all of the monikers here. But again, when you look at it, this is the back side, this is the front side. Right here are the ganglion. So this is the dorsal roots on the back side. They're sensory bundles of neurons, neuronal soma. So that's all that is. But you may hear terms kind of throughout your medical career, such as preganglionic or postganglionic. And again, for your edification, it just talks about anatomically where that is. Is it preganglionic? Is it postganglionic? Where is it in the cycle of that ganglia of sensory tissue? So that's all that means there. All right, any questions on the anatomy? Kind of just on the basic level there where we are. So the diseases that we're going to discuss today of the peripheral nervous system are 1, Guillain-Barré or Guillain-Barré, tomato, depends on how French you want to sound. Oh, Guillain-Barré. And then myasthenia gravis. Those are the only 2 ones we're going to talk about today. We are going to take a brief minute. There's 7 slides to revisit our cranial nerve disorders that we already went over. That's trigeminal neuralgia and Bell's palsy. So you already got a good grasp on that. We're just going to dig very, very minorly deeper into those, mainly just kind of a reference point. So the first one we'll talk about is Guillain-Barré syndrome. So this is a disease that results in, it's an autoimmune disease. That's the word I was looking for, excuse me. So it's autoimmune. Our body starts to attack itself. And what it does is you have these antibodies that are mediated, and instead of helping, they wind up destroying. And what these antibodies do is they go right after the Schwann cells. They go after the myelin on that axon itself. Again, that myelin, it has predetermined little interruptions in it called the nodes of Ranvier, and it's there to maximize neuronal transmission. So again, that neuronal impulse goes very, very efficiently with that intact Schwann cell with those nodes of Ranvier. What happens in Guillain-Barré is those mediated destruction antibodies go and they attack the Schwann cells, and unfortunately they don't grow back normal. They get this onion bulb appearance, as you see in that little GIF there, GIF, whatever. But when you have anatomy that's normal, and then you alter normal anatomy, it alters how that neuronal transmission goes. So it winds up slowing that neuronal transmission. And it all stems from an autoimmune disorder of destruction of those Schwann cells on that myelin. So the pathophysiology, again, autoimmune disorders are all rooted in inflammation. So you get this acute inflammatory autoimmune disorder, and it affects the myelin of the peripheral nervous system. Again, the antibodies attack that myelin sheath, those Schwann cells, and sometimes it even attacks the nodes of Ranvier, but it just breaks it down, and also the surrounding axons of the peripheral nervous system. So you get to see lymphocytes at those points of myelin breakdown. And there's different types of antibodies that attack different parts of the peripheral nerve cells. So this segmental demyelination, that destruction of the myelin in those nerve cells, it's a pathologic finding, and it just destroys that, and sometimes, like I said, the nodes of Ranvier, and it causes a slowing of a transmission from nerve to nerve in these patients. And that's the ultimate underlying pathophysiology, which leads to impaired mobility and sensory perception. And we'll talk a little bit more about that. So it is one of the rarer diseases, which is good. However, the clinical manifestations can range from mild to completely devastating, requiring mechanical ventilation and ventilatory support for quite a while for these patients. One of the hallmark monikers of Guillain-Barré is it occurs after an infection. So, hey, yeah, I just had a sniffly sneezy for a couple of days, and now I'm starting to get weak, and my gait is off, it's ataxic, I'm having trouble breathing, I can't move my legs and my arms. Probably an infection that was a good precursor. So Campylobacter is a common trigger, but it's not even close. It's any GI or respiratory. It can be bacterial. It can be viral. So there's a litany of different etiologic factors that can cause that infection, that can predispose them as a trigger. Remember, autoimmune disorders have a trigger, and this trigger infection is a big one. It affects men a little bit more than women, and it peaks after age of 55. When we talk about Guillain-Barré and that demyelination, it has a very classic symptomatology. It's called an ascending paralysis. So it begins in the legs, and it spreads to the upper arms, and then finally the upper body, the trunk. And again, it ascends the patient. It starts very, very low and works high. And as it increases in intensity, all the muscles cannot be used at all. So it winds up leading to a totally immobile patient, which again has its own subset of problems. But more importantly, that once it starts to hit the diaphragm and the accessory muscles. And what are the accessory muscles of respiration? Your intercostal muscles, your abdominal muscles, your sternocleidomastoid muscles, all of these extra muscles that help open and contract that rib cage and help pull that air in, aside from that diaphragmatic contracture, which creates the negative pressure. But once that starts to get affected, well, now the ventilations are a problem. The good thing about Guillain-Barré is that the healing occurs in the reverse order. So the thing that's affected last, and in this case would be respiratory, facial, swallowing, starts to come back first. So that's one of the good things. It follows a kind of a predictable course, Guillain-Barré. It's got a couple of stages. That first stage is the acute phase. It can last 1 to 4 weeks. It's where the symptoms come on, they start getting worse, start getting worse, start getting worse, start getting worse, and then they stop. They kind of reach this plateau period where there's no worsening, there's no betterment. And that plateau period can last a couple of weeks. There's no changes in the patient's condition. Then they start to slide into the recovery phase. The sad thing about the recovery phase for Guillain-Barré is it's gradual. It can take a couple of months for some patients. It can take a couple of years for other patients. And there's absolutely no predictable course of how it's going to recover, how speedily or rapidly it's going to recover. So it's a great educational point for your patients, taking in that psychosocial factor that, and their family, that this isn't going to happen overnight. There's not a one drug or one pill or one thing that's going to make it come back. And it's all thought to kind of coincide with the remyelination of axonal degeneration. It takes time to regenerate that, sometimes up to years. Some patients sadly don't completely recover. They may have some residual permanent neurologic deficits. We kind of pigeonhole those patients as a chronic Guillain-Barré syndrome. They're not having exacerbations and relapses. They're just kind of there. They never came back to baseline. Usually by about the 7th day, about after a week, most of the patients achieve their nadir and neurologic function. 98, about 4 weeks, in about a month. And a clinical nadir is a nice fancy term that says their symptoms are at their worst. So that's it. That's the peak. So now that we understand what predisposes a patient, what causative factors, what triggers Guillain-Barré syndrome, how do we assess our patients? What do we expect to see? Well, in the mobility category, again, if it's an ascending paralysis, they're going to start with maybe some paresthesias, some burnings in the lower extremities, bilateral muscle weakness and paralysis starting in the lower extremities, so that's going to affect their gait and mobility. And it's a flaccid paralysis. It's not spastic. And there's no muscle atrophy, so they don't get that wasting away, which is a good thing. It's symmetrical, so you don't get one versus the other. They will have a decrease or loss of deep tendon reflexes as it starts to ascend. And they have the inability to sense vibration, amongst other things. And respiratory compromise when it starts to reach the diaphragm. So what do we see clinically with respiratory compromise? Well, first off, they're going to be dyspneic. They're going to have trouble taking breaths in. You're going to see them kind of pulling, using to the extent those accessory muscles. You're going to have diminished breath sounds. They're not taking as deep a breath, which again goes into decreased tidal volume and pigeons in vital capacity. Those are all linked together. And that's going to reduce the SpO2 of that patient. So these are things that we can objectively see and subjectively they can talk about, and then we can actually quantifiably measure in a form of an SpO2 and vital capacity and tidal volumes. Ataxia is going to be a little bit early on, and that's something mobility-wise that we have to worry about safety. Safety is falling and tripping hazards. Loss of bowel and bladder control. This sets them up for infection. It sets them up for breakdown, which again could be a secondary skin infection on top of that, particularly if you pepper in the fact that they have a sensory perception problem. They're not going to know if they're incontinent. They're not going to feel that normal feeling. So the paresthesias are one thing. That's very, very painful, but they're also going to have some subsequent cramping intermingling it because it's not an on-off switch. It slowly starts to take over. They have cranial nerve manifestations. That's facial weakness, dysphagia, double vision, difficulty speaking. As nurses, let's put our nursing hat on. What are we worried about when we have cranial nerve involvement? Anyone? What should be the big red flag that pops into our nursing minds? Aspiration, 100%. Yes, excellent job. Aspiration, aspiration, aspiration. You definitely want to worry about these people choking. Right. And then there's autonomic manifestations. Remember, that's going to talk about blood pressure, cardiac dysrhythmias, and maybe tachycardic, bradycardic. Labile just mean change. So they may have hypertension mixed with hypotension. It's up, it's down. But we need to be on the lookout for that. For our visual learners out there, this is in the PowerPoint. You can right-click and save this. It's a nice visual overview of Guillain-Barré syndrome, of the pathophysiology of it, and kind of what to expect along the way. So what do we do to diagnostically work it up? Well, there's really no single lab test or clinical test that confirms the diagnosis. We can do a lumbar puncture. We're going to see a lot of protein, mainly from the inflammatory plasma proteins, because again, autoimmune disorder, inflammation is the hallmark of it, and that myelin breakdown and the damage to the nerve roots. So that's what we can see in the CSF. It's usually elevated 1 to 2 weeks after the onset of symptoms. But one of the things we can do are nerve studies to find demyelination, find neuropathies, and usually within about 3 weeks after symptoms, you start to do these nerve conduction velocities, and they're depressed. Has anyone heard of nerve conduction tests? Or a thing called an electromyogram, EMGs? So EMGs are pretty cool because they reflect a peripheral nerve function. Yeah, I'm going to show a video. I think it's important that we all understand what these are for our patients to go through because they're going to hear things. So an EMG, they put needles into the muscle. Well, that doesn't evoke such a wonderful visceral response for many people. So let's look at that and see what that is. So it's normal in the early illness to do these, and the changes appear after the denervation of the muscles has been present for about 4 weeks. There's also nerve conduction velocity testing. Those are kind of done in concert with EMGs. They're separate, but they kind of measure the nerves itself. And I have a great video, and this woman does a fantastic job explaining it. And I think it's important for us to see these videos.
The motor fibers have more myelin. And here is how we measure the speed. This device will give an electrical shock to the nerve. Here it is the median nerve above the wrist. And these are surface electrodes that will detect the shock that was discharged by this device. The technician will then measure the distance between the device emitting the electrical shock and the sensor. The machine will tell the time it took for the electrical current to go from point A to point B. Then the technician will calculate the speed in meters per second. Normal speeds are usually around 50 to 60 meters per second. If the calculated speed is lower than expected, then it might be that there is a lesion in the nerve here. The speed of a nerve is determined by the amount of myelin around the nerve. If the myelin is damaged, then the speed in this region will be decreased. The analogy is like an asphalt road that is damaged and the cars can't go fast. There are some diseases that cause a problem of the myelin, for example, multiple sclerosis, MS, and diabetes. Now, let me explain the electromyography part. In order for us to know how many axons are getting to the muscle, or in our analogy, how many lanes of the highway are open. We must ask the muscle to contract, and then we can see and hear the recruitment of the muscle fibers. If all axons are connected to the muscle, or all lanes are opened, then we will see and hear a typical noise that shows a lot of activity in the screen. If we see a few fibers being recruited, then we know that there is some blockage or loss of axons. Some people get scared with the word needle. Here is an EMG needle. Well, in fact, this is not a needle. It's like the one that we give injections. This is a monopolar electrode. You see it's very thin. This is an injection needle that we use to inject. It's thicker than the EMG needle, but the EMG needle is almost like an acupuncture needle. It's thicker than an acupuncture needle, but it's thin. So the doctor will stick this electrode inside of the muscle, then look at the computer screen, and will ask the patient to contract the muscle slightly, then stronger, then very strong. The doctor will also pay attention to the sound that is coming from the muscle, and the higher the sound, it means that there are more axons working or more lanes are opened. There are diseases that affect the axons.
So again, if you didn't have an idea of what nerve conduction studies were or what an EMG actually is, I think she does a really good job at explaining that. And it's good to kind of alleviate some of the fears of the patients when it comes to that needle aspect of it. In the morning's class, there was someone who actually had these done and said there was just only parts of it that were mildly discomforting, but most of it was very, very tolerable. But I think it's important that we get to see exactly what those studies are in case you have a patient that goes for one of those. Okay, so the other things that we're going to do is do an MRI and CAT scan. Always remember our differential diagnosis. We want to rule out other organic causes of this paralysis and paresthesias. So we look for tumors, we look for bleeds, we look for strokes. So that's what we're going to do, is make sure we rule those out also. So we're going to check respiratory function. So we can do vital capacity or tidal volume in ABGs, and we can get a good bead on how they're doing, how they're progressing, or how they're deteriorating, depending on what stage they're in Guillain-Barré syndrome. So diagnostically, those are what we can look at for these patients. So when we talk about interventions, how do we treat Guillain-Barré syndrome? Well, it's an autoimmune disease, so we have antibodies that are wreaking havoc all over the body. Well, one thing we can do is a thing called plasmapheresis, or therapeutic plasma exchange. And this removes all the circulating antibodies. They're not good, so let's take them out. So you take everything out. The blood comes out from the patient, and then they separate out the plasma from the blood. The blood is fine, so that goes back to the body, and the plasma will replenish itself. And if we need to add volume, we can give them some sort of colloidal substitute like albumin, and it's usually initiated within several days. But the key thing of plasmapheresis is to get rid of those antibodies. Has anybody heard of plasmapheresis before or seen it? It's a fun word to say. It confuses a lot of people because we don't really know what it means. But I got a quick video here to show you. It doesn't go over anything. This is actually a patient. It's a video of a patient's room of someone on plasmapheresis. So as you as nurses, if you're taking care of these patients, this is kind of what to expect to see. There's no audio to it, but you can see the litany of different fluids. There's the plasma that's coming out. And it's a very complicated machine, but it does a lot. Again, you would go through special training if you were to deal with this. But you can see, in addition to just what the patient's on for medication-wise, and what their traditional therapies are, there's this whole plasma exchange going on in the background, done at the bedside, and it's done through a central venous catheter, as you can see in this patient's neck there. It's a central line. It's pulling it out, returning the blood back in, and it's really getting all of those antibodies out of the system that are wreaking havoc. So again, this is just neat so you can actually see what to expect if you do wind up taking care of a patient this semester or in your nursing career that does get plasmapheresis. Okay. All right, so aside from plasmapheresis, one of the things we can give them is IVIG, IV immunoglobulin. And you may have heard of this too. So IVIG is pretty cool. It's from donated blood that contains healthy antibodies. So somebody who has normal, healthy antibodies, they donate it and they spin them out and they create IV immunoglobulin. It's very effective, as effective as plasmapheresis. But the cool thing is it's immediately available. You don't need all this special machinery. You don't need central line access. The key thing with this, it's kind of like giving blood. You want to start it slow. You want to observe for side effects like chills or fever, myalgias, or there's some serious side effects with IV immunoglobulin. And more severe reactions can be anaphylaxis, meningitis, retinal necrosis, acute renal failure. So again, it doesn't go without having potential side effects. And again, risk-benefit ratio really comes into play when you start to talk about therapies for patients. Intervention-wise, this is what we as nurses can do. They're at risk for respiratory failure, so frequent respiratory and cardiac assessments, respiratory rates, tidal volumes, listen to their lungs, listen for the development of adventitious sounds. So I know it sounds silly, but we want to promote airway patency and adequate gas exchange. Patient positioning, simple things like chest physiotherapy. Has anybody here seen chest physiotherapy done? Clinical, personally, yeah. Do you want to describe it, Christina? You don't have to.
It's like a vibrating like chest, like a vibrating, almost it goes on the chest. It looks kind of like a bulletproof vest almost, and it
Yeah,
vibrates the chest and it breaks up secretions that the patient's having and it helps them breathe better.
100%. Yeah. Now there's old school chest physiotherapy, and that's what I was introduced to it. I was a nursing student, and I thought a respiratory therapist was beating at my patient because they were just using cupped hands, and the patient was prone, and they're just cupping, and they're just hammering on the patient's chest. But it does the exact same thing: is it breaks up all that tenacious sputum. It wants to help promote to get that out, minimize the risk for secondary infections. But yeah, that's exactly what chest physiotherapy is. We want to frequent position changes, again, combined with breathing exercises, cough, deep breathing. That's why we rotate patients and turn them so that one lobe doesn't harbor all this mucus and all this fluid, which stagnates and lends for bacteria, and then they can get a pneumonia down the road. The incentive spirometer, that helps force them to take a nice deep breath. We can also indirectly kind of get a good measurement of what their tidal volume is. They may need supplemental oxygen that we can provide, and ABGs and end-tidal CO2 for respiratory failure. The ABGs kind of start to wean off a little bit. With the proliferation of end-tidal CO2, particularly with the technology that's out there, I mean, we can do that bedside monitoring for end-tidal CO2, which gives us a really good real-time feedback of how their respiratory function and indirectly how their perfusion status works. We know that if there is a decrease in their vital capacity, usually about 15 to 20 milliliters per kilogram, we wind up kind of leaning toward intubation, particularly if they can't clear their secretions. So we need to open up those airways. And intubation and mechanical ventilation, after maybe a week or two, they might wind up just getting a trach. Again, a prolonged endotracheal tube with a cuff can cause necrosis of that tracheal lining, so they get rid of that actually pretty quickly. Much more quicker, I don't know if that's much quicker, more gooder than it used to in the past. They used to not kind of trach patients. Now it's such a safe bedside procedure that they do it fairly quickly. Also going to monitor their cardiac function. Again, there's an autonomic component to it, so we look for dysrhythmias. If there's hypertension, we can treat them pharmacologically with medications like nitroprusside. That's a very potent vasodilator. And if they're hypotensive, we can treat them with IV fluids. We can lie them supine. Remember, gravity's our friend, unless there's respiratory issues. So this is that next level thinking. So if you have a patient who's got a blood pressure of 80/40, well, our immediate thing is, well, let's lie them flat. Well, but their pulse ox is 88%. So do we want to lower them and now their pulse ox is 78%? Or do we want to keep them up? It's kind of a delicate balance. So we as nurses, if you have somebody within that category, you have to do that critical thinking. You're bridging those different disease states and go, okay, maybe some supplemental oxygen, maybe we can lie them back a little bit, we can give them some fluid, listen to their lungs, make sure they're not going to congestive heart failure, and kind of treat our patient holistically, for lack of a better term. And if they're bradycardic, we can give them medications like atropine, which will increase the heart rate. Other interventions are aspiration precautions. You probably put those together now and connected the dots that all of these modules, and even going on, aspiration precautions are there. So you'll see stuff on the test about aspiration precautions. Make sure that the head of the bed is elevated 30, 45 degrees. You definitely don't want them supine. Test for dysphagia. If you have somebody that has a disease that's slowly starting to nip away at maybe the cranial nerves, test them first. Here's something small, then you can start giving them oral drugs or nutrition to make sure, but that's kind of going to be a daily test. Make sure that you have suction at the bedside, make sure that the suction's there, it's available, it's working. Orotracheal suction for compromised airway or secretions. And again, we can do that as clinicians. If some patients have a retention of upper extremities, it's not uncommon to have a patient hold on to their own Yankar for a while. Venous thromboembolism prophylaxis and PEs, they're common because immobility is a huge factor of it. So we put them on anticoagulants like low molecular weight heparin, Lovenox, or sequential compression devices. Our friends PT, OT, and speech language pathology, they come in, make sure to minimize any secondary problems or tertiary problems, and we assist them with walking. Remember, ataxia is one of the early things, so we want to make sure that they don't fall. These patients are not only an aspiration risk, they're a fall risk too. Maintain proper body alignment. We don't want to cause contractures or foot drops, and encourage maximum independence for as long as they can. Again, safety is going to be a huge parameter that we look out for. We monitor for fatigue and muscle weakness. We also want to monitor nutrition. Again, they have dysphagia. Anyone who's dysphasic is not going to get the proper nutrition, so we keep an eye on it. We offer small, frequent meals. We make sure that they can take that, or we may need to give them supplementation for it. So here's a quick question. An older patient is hospitalized with Guillain-Barré syndrome. A family member tells the nurse that the patient is restless, seems confused. What action by the nurse is best? Assess the patient's oxygen saturation, check the medication list for interactions, place the patient on a bed alarm, put the patient on safety precautions, or request a urine sample for a possible UTI. What do you think? A, B, C, D, or E? Got D, I got A. Patient's restless and confused. I got A's, 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 A's. Yeah, A is the correct thing. Again, they're all correct. Whenever you see something that says what's the best action, it means all of them fit. But again, ABCs, oxygen saturation, Guillain-Barré, we know that it can affect respiratory function. So let's put a pulse ox on them. Let's see what's going on there. Yeah, we could check the medications for interactions. What's one of the key things for elderly that we see for an undiagnosed UTI is exactly this, confusion and restlessness. However, ABCs. So yeah, strong work. Good job. Another question. What is a common precursor to the onset of Guillain-Barré symptoms? Hypertension, high cholesterol, a prior MI, or a recent infection? What do you think? A, B, C, or D? Yeah. Yep. Recent infection. That's weird. That's like the third time I said that, isn't it? That's crazy. Any questions about Guillain-Barré syndrome? Everyone feel pretty good about it? Cool. If there's any questions, pop them in, and we'll segue into myasthenia gravis. So I think what people are concerned about with Guillain-Barré myasthenia gravis is they get them confused and back and forth. So let's make myasthenia gravis a little bit easier for you. So myasthenia gravis is caused by an autoimmune disorder, but it attacks acetylcholine receptors. And we heard acetylcholine way back in Parkinson's. So acetylcholine and muscle end plate causes impaired transmission of nerve impulses. There's not enough acetylcholine. So when there's not enough acetylcholine, that the nerve impulses are reduced at the neuromuscular junction, so there's no muscle contraction. Remember, in Parkinson's disease, there's an imbalance between dopamine and acetylcholine, so there's too much. And we know when there's too much, you get muscle rigidity and the mask-like face and the festinative walk, the posturing, the rigid. Well, if you don't have enough, you wind up getting flaccidity. And that's kind of what the hallmark is. Think acetylcholine, and there's not enough, so they're going to be tired, fatigued, weak. Sometimes it has to do with a hyperplasia or an overgrowth of the thymus gland, but it's characterized by progressive fatigue. It gets worse with activity, and think, you have X amount of acetylcholine, I start exercising, and acetylcholine gets eaten up quickly. I don't have enough, I'm going to be fatigued. It gets worse, the symptoms come back. It improves with rest. Okay, I'm going to build up my reserves. I'm not using so much acetylcholine. They're a very, very high risk for aspiration. As a matter of fact, this disease state has the highest risk of aspiration. Said that twice. And it's an acquired autoimmune disease. So what do we know? We know that acetylcholine stimulates muscle contraction. We talked about that. So if there's not enough, there's muscle weakness or no contraction at all. There's also those things called acetylcholinesterase. So you remember from week 1, we had this little picture of a neuron here in the synaptic cleft, and we can have problems with production of a neurotransmitter, we can have problems with reception of a neurotransmitter, or we can have problems with something eating up the neurotransmitters. And that's what acetylcholinesterase does, is it breaks down acetylcholine. So again, if we know normal anatomy, we know where it can go abnormal. It also gives us a route for treatment. So if you stop it from working, you get more acetylcholine. So if we can inhibit acetylcholinesterase, more acetylcholine, more muscle contraction. So the myasthenia gravis damage, it really occurs right at this synaptic junction. That's where it kind of takes place. So weakness patterns are most commonly in the face, neck, and trunk muscle. They're called bulbar muscles. In most advanced cases, all the muscles are weakened, but it's been described as proximal to distal. What is this opposite of? If this one's proximal to distal, what disease state is distal to proximal? Yeah, Guillain-Barré. It's the exact opposite. So when you think about it, when we talked about these patients being at most risk for aspiration, because where does it hit first? Right in the face. Boom, right in the bulbar muscles. So they're at risk for dysphagia, which puts them at risk for aspiration. That's the first thing that gets hit, all those muscles. Most of them report visual disturbances first. And think about your eyes. You're constantly scanning the environment. You're constantly blinking. So those muscles require acetylcholine to contract and move your eyeballs around. They're going to get fatigued quickly. And that fatigue winds up being like double vision, or a thing called amblyopia, where one eye's looking over there, one eye's looking over here. And ptosis, where their eyelids start to droop because those muscles are constantly being used and constantly gobbling up their acetylcholine reserves. It can be, in many forms, very mild to rapidly developing. They may have generalized weakness, and in severe forms, respiratory failure and death, much like Guillain-Barré, just a different pathophysiology. It can present at any age, but it's usually seen in women under 30 and men over 50. It's a very slow onset, but you can have a rapid development if it's caused by an infection, pregnancy, or anesthesia. Remember, it's an autoimmune disorder, and there's triggers. And some of these triggers tend to pull the trigger a little bit quicker, for lack of a better term, like infection, pregnancy, and anesthesia, so it can exacerbate the onset and development. It may be associated with a thymoma, which is an overgrowth of the thymal gland. And temporary weakness is sometimes noticed just after vaccines, menstruation, exposure to extreme temperatures. Remember, multiple sclerosis, we talked about that as temperature, extremes. Again, autoimmune disorders, they're really funky. And again, that bulbar involvement, muscles of the facial expression, chewing, and speech, high risk for aspiration. So when we assess these patients, our motor manifestations are affecting mobility. So again, it's proximal, hits the mouth, eyes, face first, and then it starts to worsen, and particularly with repetitive use, but it usually improves with rest. There's respiratory compromise that can happen, and again, they're going to start to have a poor posture. Think about sitting upright. You're using your abdominal muscles, your back muscles, your chest muscles constantly, and particularly if you're standing up, you're constantly keeping that in balance. Well, you're fatiguing those muscles. You're wasting that acetylcholine, so the posture starts to weaken. Ocular palsies, diplopia, and ptosis, like we spoke before, the eyes are constantly moving, you're constantly blinking. Easiest way to chew up that acetylcholine reserve. Hoarse voice, they may have trouble swallowing, aspiration precautions. Loss of bowel and bladder can happen. Fatigue is a huge one. Less often affected are muscles of the shoulder, flexors of the hips and head, but they may have difficulty climbing stairs, lifting heavy objects, or raising their arms above the head. The neck weakness can be very severe to the point where they may not even be able to hold their head erect, which again puts them at secondary problems of airway compromise. Difficulty sitting or walking for long periods of time, and again, rarely they get muscle atrophy. Sensory and perception manifestations, they get muscle achiness, paresthesias, and sometimes you get a decrease in smell and taste with these patients. Again, bulbar involvement, face. Diagnostically, for Guillain-Barré, we check for hyperplasia of the thymus. We can do an MRI or a CAT scan. We look at the gland itself, and we just see if there's any thymomas. And if there is a thymoma, clinically we see a little bit different presentation. It just tends to stick to the bulbar, ocular, and neck muscles. and sometimes the respiratory. It rarely affects the limbs. So if you see that and it doesn't progress to the limbs, it's probably a thymoma underneath there. We check their thyroid function. There are a degree of patients that get a thyroid toxicosis, which is a small number of these patients. And we check for other immunologic diseases like rheumatoid arthritis, lupus. So the weird thing about autoimmune disorders is they like to kind of group together. If you have one, there sometimes is a latent one hanging out underneath because they tend to trigger each other too. They're going to be positive for antibodies against acetylcholine receptors. So if you test them and they have positive antibodies, it confirms the diagnosis. Although if you test it and they're negative, it doesn't necessarily rule it out. If you're lucky and it's positive, then yay, but when it's negative, it doesn't mean the testing stops there. It's kind of like a D-dimer for someone with a blood clot. You know, if it's there and it's positive, perfect, you know, or it's negative, perfect, it says we don't have a clot. But if a D-dimer comes back positive, it can be a litany of things. It can be a clot, it could be an infection, it could be age, it could be pregnancy, so it doesn't necessarily confirm the presence. We can do things called repetitive nerve stimulation, like we saw that video for, and the EMGs. So this patient population kind of gets the same basic testing. Although there is one definite test that we can do that really confirms myasthenia gravis. So it's confirmed on their response to cholinergic drugs, particularly one drug called edrophonium, which is called Tensilon, is the main word for it. It has a very rapid onset, but a very brief duration, only a couple of minutes. It is a cholinesterase inhibitor, so it stops the breakdown of acetylcholine, so hence we get more acetylcholine. It's called the Tensilon test. They give it intravenously, and in about 30 to 60 seconds, you start to see a dramatic improvement in muscle tone for patients. And why? It's because it's a cholinesterase inhibitor. We have more acetylcholine all of a sudden for that brief period of time. I have a quick video to show you, and trust me, I scoured the internet, and the only video I can come is from 2001, so I apologize for what it looks like. However, it's still the same, so let's play that here. So as you can see, there's no audio to this. This gentleman, they have him on a cardiac monitor, so they're watching that. They have an IV in place, but you can see bilateral ptosis. He can't keep his eyelids open. Now they'll pull him open, and they're going to ask him to do some, extraocular movements. So look up, look down, look left, look right. When he starts to look side by side, ooh, look at how amblyopic he is. That one's looking over at Istanbul. This one's looking at the U.S. So that's very common. Those eyes can't conjugate. So they gave him 10 milligrams intravenously, and we're going to watch over a few seconds. So now you can see his eyes are converging. He's able to open his eyelids a little bit. His left is starting to take present far more than his right. And only after a few seconds now, both eyelids are open, the ptosis is gone, he can fix his gaze, he can look. So that right there is a positive Tensilon test. This guy's got myasthenia gravis. What a dramatic difference this is from this. So this is him in a normal state, and this is him after that IV. And this will, again, after a few minutes, go right back to this particular picture, just because it's going to start the acetylcholinesterase gobbling up again. But I think it's a great video to see that, of how that actually works with the patients. Okay, so intervention-wise, IVIG, we talked about intravenous immunoglobulin. Again, pooled human GABA globulin, simply gamma globulin. So they're lacking the antibodies. Let's give them fresh, good antibodies. Somebody last class asked, what's the difference between a good antibody and a bad antibody? And I initially said the bad antibodies have a bandana over their head. The good ones have a badge. So it's pretty easy to see them under a microscope. But realistically, what it is the bad antibodies for an autoimmune disorder, they just, instead of attacking a pathogen, they attack healthy tissue. So a good antibody is going to go in there and attack the bad antibodies and get rid of them, actually. IVIG is very effective for these patients in myasthenia gravis. And again, it competes with autoantibodies that reversibly interfere with the nerve conduction. So one of the key things you want to take away is that the increased catabolism of these pathologic antibodies. So in myasthenia gravis, IVIG, immunoglobulin, reduces production of acetylcholine antibodies. So immunoglobulin, IVIG, reduces production of acetylcholine antibodies. Weird, said that twice. And then, of course, plasmapheresis. We can do that also. Same interventions. Pharmacologically, though, for myasthenia gravis, we have some other interventions we can do. We can give them pyridostigmine, cholinergic drugs. They're anticholinesterase. They inhibit the destruction of acetylcholine, so it increases the concentration of acetylcholine. So the doses change daily depending on the patient's need, timing of giving the medication. Immunosuppressants can be given. Surgically, we can do a thymectomy. That's kind of more of an extreme thing where we remove the thymal gland. And we need to educate our patient, and we educate the family on resuscitative procedures. If it happens quickly, they need to know how to intervene, how to open the airway, do BLS, call 911. Educate them on the episodic nature of the disease. Much like multiple sclerosis, they need to avoid things like infection, stress, hard physical exercise, sedatives, enemas, strong cathartics, alcohol, saunas, hot tubs, sunbathing, crowding, and overheating. The other thing is we want to teach them about medications that worsen the myasthenia gravis. More importantly, we want to tell them never to start a medication over the counter or other prescribed until they check with their pharmacist or their doctor. Because here's just a brief list of medications that interact with myasthenia gravis patients and can really wreak havoc on them. And it's huge. So it's very important for them to check with their pharmacist and their prescribing neurologist when they take any other medication. This week's assignment, we talk about a myasthenic crisis. And I'm kind of going to go back and forth between what a myasthenic crisis is and a cholinergic crisis is. So in a myasthenic crisis, you don't have enough acetylcholine. So if there's not enough acetylcholine, that can be from us. Maybe we underdosed them, or maybe they have something going on. They have increased stress or respiratory infection or something that's causing them to gobble up the acetylcholine. And it leads to muscle weakness and respiratory failure. They have dilated pupils, increased pulse, increased respirations, increased blood pressure. Geez, what does that sound like? What part of the nervous system? The sympathetic nervous system. Sympa is stress. Decreased urine output, bowel and bladder incontinence may happen, absence of cough and swallowing reflex. Again, that's a reflex. I kind of keep seeing it. I say it and I forget to go back and change it. Not a reflex. But again, risk for aspiration. And it improves with the tensilon test. So if they give them the edrophonium, all of a sudden, boom, they get better. The opposite is a cholinergic crisis. So that's way too much acetylcholine. That's, maybe we gave them too much of the medication. We overdosed them on their cholinergic inhibitor, cholinesterase inhibitor drug. So the end result of both of these is muscle weakness and respiratory failure, but the difference is in a myasthenic crisis, you just don't have enough. In a cholinergic crisis, you have way too much, so you overstimulate the muscle, which leads to exhaustion. Opposite symptomatology. The pupils are constricted, blurred vision, slower heart rate, lower blood pressure, bronchoconstriction and bronchospasm, flaccid paralysis. They get a hypersecretion of everything. And there's a little acronym called SLUDGE. And it's salivation, lacrimation, urination, defecation, and esophageal hypermotility. Same thing you would see in an organophosphate poisoning for pesticides. Nausea, vomiting, diarrhea, abdominal pain, and the onset of muscle fasciculations, which is twitching. It gets worse with the tensilon test. You think about that. If you give them edrophonium, you inhibit the cholinesterase, all of a sudden they get more acetylcholine, it's going to get worse. The treatment is atropine. We give them atropine and we hold that cholinesterase inhibitive medication. I told you week 1, there was a picture. I put it in this week's slides, cholinergic versus anticholinergic. If you're a visual learner, this is a great one to right-click, download, and it gives you just another way to review. All right, quick question. What intervention reduces acetylcholine antibodies? Is it pyridostigmine? Is it IVIG? Edrophonium? IV atropine? Which one reduces acetylcholine antibodies? A, B, C, or D? Any guesses there? I snuck it in while we were talking. Absolutely. BBB, IVIG. It reduces acetylcholine antibodies. That's 4 times I said that. Isn't that crazy? God, I need to get my head checked. All right, myasthenia gravis patients have ascending paralysis, distal to proximal. Is that true or false? Myasthenia gravis is ascending. It starts distal and works proximal. True or false? That is correct. False, false, false. It is proximal to distal. Good job. So I'm going to reach out to the group here. It is 2 o'clock. We have 6 slides left. 6. You want to just power through the 6 slides, or does anybody need a break? Keep going? No break. I agree. Power through. I had to stop this morning because I had to pee so bad. So let's go. All right. And this is just review. All it is review. So cranial nerves, when we talk about it, again, just the overview, they emerge directly from the brain, including the brainstem, in contrast to the spinal nerves. The cranial nerves rely on information between the brain and parts of the body, but primarily regions of the head and neck. It kind of makes sense. Although they're considered components of the peripheral nervous system, which is kind of strange, and they develop in the central. But structurally, the olfactory, optic, and trigeminal are more accurately considered part of the central nervous system. So it's just semantics. And we're going to review our friend Bell's palsy. Bell's palsy is facial paralysis, cranial nerve number 7, could affect 5 and 8. Most often one side, it's usually one side. That's one of our differentiating features. It affects all ages, but younger adults. They cannot close their eyes, smile, whistle, or grimace. And they can't wrinkle their forehead. Kind of weird. Causes inflammatory response from a formerly dormant herpes simplex virus or some other infection, and altered immunity. So intervention-wise, steroids, again, it's an inflammatory response, antivirals, mild analgesics, physical therapy, facial massage, facial exercises, warm and moist heat. A lot of these things are going to be preventative, like an eye patch, the unaffected side. Protect the cornea from drying and ulceration and abrasions. Anyone's had a corneal abrasion, they hurt a lot. I've had multiple of them. Patient may have to manually close their eyelids, instill artificial tears and ointments at night to make sure that there's no ulcerations. Eat and drink on the unaffected side. Again, risk for aspiration with these patients. High-calorie snacks. Again, anyone with dysphagia is at risk for malnutrition. Nerve blocks are rare, but they can do that for pain. And this is a video, if you choose to watch it. It goes over a news reporter, and she talks about her journey from symptomatology, diagnosis, workup, and then kind of rehabilitation. And it affects her because, for lack of a better term, it's her moneymaker. I mean, that's her face. That's what she talks with. She's a news anchor. And she still has some residual effects. So if you are curious and want to watch that, it's a good video. So what other disease can Bell's palsy be confused with? Trigeminal neuralgia, Guillain-Barré, CVA, or myasthenia gravis? What do you think? What can Bell's palsy be? Yeah, 3, absolutely. CVA. And they're flaccid on one side, but it's only to the face. No systemic involvement. All right, trigeminal neuralgia, just to revisit that painful tic. It affects cranial nerve number 5, cinco. And cranial nerve 5 has 3 branches. It has that first branch, which is the upper lid, the eye, and the forehead. That's that green ophthalmic zone in the picture. The second is the sensation of the lower eyelid, cheek, nostril, upper lip, and upper gum. That's that pink maxillary zone. And the third is the sensation in the jaw, lower lid, and gum. And some of the muscles of chewing, that mastication, and that is in that purple mandibular zone. It is a chronic syndrome. It's characterized by patients usually over 55, women a little bit more than men. It's this really sudden, intense facial spasm. It's provoked by minimal stimulation. We spoke about that earlier. Unilateral, it's confined to the area innervated by the trigeminal nerve, usually just the second and third branches, those lower ones. It's got a familial tie to it, so it has an inherited pattern and has to do with blood vessel formation. I have a video that shows kind of neat on that. The pain is exceptionally severe with these patients. And I'm going to underscore the fact, because I think trigeminal neuralgia, and you're like, oh yeah, it's facial pain, they twitch. When it comes to treatment options, you're going to see how severe it is. It's not life-threatening, but it can be very debilitating. About 15,000 people a year in the United States are diagnosed with it. So intervention-wise, we have to deal with the pain. So pain management, pharmacologically, we can give them some of these anti-epileptic drugs, actually. Carbamazepine, gabapentin, and Lyrica. All of those help, although they're anticonvulsants, they help with neuropathic pain. They're very, very good with the neuropathic pain. They alleviate pain by decreasing conduction of sodium channels, so it inhibits all these ectopic discharges. Baclofen, what's baclofen for? What kind of medication is baclofen? Because we heard about that in a couple chapters. Modules, I should say. Yeah, it's a muscle relaxer. So again, that's a medication we can give patients. We want to make sure that they're not sleepy before we give it, and we don't want to stop it abruptly. And surgeries. And this is where it really occurred to me, it was an eye-opener, how painful trigeminal neuralgia is. So one thing they can do is microvascular decompression. It's the most long-lasting. They decompress the artery, again, pressing against the nerve. They can do nerve blocks, and then stereotatic rhizotomies, which is radiofrequency lesioning. They heat, current, and then they kind of burn the nerve. I got video here, which really, really opened my eyes to how severe trigeminal neuralgia is.
Every case has a unique anatomy, but in many cases, the artery has a long loop, and that loop can sometimes get stuck right where the nerve comes out of the brainstem. And when that loop of the artery gets stuck there, it can wear down the lining on the nerve and then make that part of the nerve very raw. That injury to the nerve, that compression over time, is actually what causes the pain. One of the most important surgical treatments for trigeminal neuralgia is called a microvascular decompression. During this procedure, a small incision is made behind the ear, about 2 inches long. We then use a drill to actually drill out a piece of the bone about the size of a nickel. And through that hole, we actually use an operating microscope to see where the nerve is coming out of the brainstem and to dissect the artery off that nerve. Now, even though this is a kind of brain surgery, there is no cutting of any brain tissue itself. All we primarily do in the surgery is to separate the artery from the nerve without trying to go through or injure any brain tissue. That procedure is about 80 to 90% effective in stopping trigeminal neuralgia pain, and it usually happens immediately. Another important treatment for trigeminal neuralgia is called radiosurgery. Radiosurgery is a way of delivering very focused radiation just to the nerve itself. The goal is to block the transmission of that pain information in that nerve. It's an outpatient procedure where patients get to go home the same day of their treatment. At UCSF, we offer 2 types of radiosurgery. One is called Gamma knife, and the other is called CyberKnife. Both of these allow very targeted focused radiation to treat the trigeminal nerve. We offer both of these, however, over time, we found that the Gamma knife has been a much more reliable treatment option. Patients have had much better pain control with much less side effects. So at this time, we prefer using Gamma knife for treatment of trigeminal neuralgia. However, it's not typically as effective as the microvascular decompression. We typically estimate that about 60 to 70% of patients will become pain-free after this procedure. And the recurrence rate for trigeminal neuralgia is higher from Gamma knife than it is for the microvascular decompression. About 50% of patients at 5 years will have recurrence of their facial pain. The third surgical treatment for trigeminal neuralgia is called radiofrequency lesioning. Radiofrequency lesioning is done by introducing a needle probe actually through the cheek at the side of the mouth. We use X-rays during the surgery to guide that needle to the base of the skull. And the needle is very gently and delicately introduced through a hole at the bottom of the skull called the foramen ovale. The foramen ovale is a part of the skull where the trigeminal nerve has branches that exits the skull. And it's through that opening that we can actually introduce the nerve probe to an important part of the trigeminal nerve called the trigeminal nerve ganglion. The radiofrequency works by introducing heat, and it heats up and injures part of the nerve that helps desensitize the nerve, and through that it actually interrupts the transmission of pain information from the face. One of the big differences between radiosurgery and radiofrequency lesioning is that the radiosurgery is very non-invasive. It's actually not a surgical procedure. It's a radiation treatment. And it has about 20 to 30% chance of having facial numbness, but it may take time for the benefit to actually kick in. On the other hand, the radiofrequency effects typically control the pain right away, but in almost all cases it's associated with causing some facial numbness. Overall, all of these procedures are very effective at treating trigeminal neuralgia.
So did you have any idea that it was that invasive of procedures for trigeminal neuralgia? I didn't. I'd be 100% honest with you when I was researching this to find something to show you that. It was amazing to me how invasive and intrusive those procedures are, and more importantly, how painful that must be to say, yep, that's the treatment that I want. Go crack open my skull or go shove a needle up through my cheek into the ganglia there. So, all right, quick question. Which cranial nerve is affected in trigeminal neuralgia? Cranial nerve 4, 7, 5, or 10? What do you think? 1, 2, 3, or 4? What is it? Cranial nerve 4, 7, 5, or 10. Yeah, 33333. It is Cinco. Cranial nerve Cinco. That's it. That's this week. That's this week. Let me stop sharing that. Let me put on my video and see if there's any questions. Are you okay with it this week? Is it pretty okay? Digestible? Kept it short, sweet, to the point? Yeah. I figured, week 3 is a good break after all the neuro stuff. Next week's lecture, I'll put that up today. You're welcome to view that at any time. Just be sure that you view that. And there's no code word today. That's a great question when the next code word is. I think it's next week. If I was good at my job, I would probably know that off the top of my head. But I just kind of fake it till I make it these days. So let's see. Perioperative. Yep. Yep, there is a live classroom. It's embedded within the lecture. So, yep, it's next week. ATI next week. I'll make sure that the MedSurg ATI is open up for 922 cohort. Yeah, it's on 1 through 4. That's it. The first 4 modules, 75 questions. You have 113 minutes. It is on campus, so the on-campus exam will be at 1:30 p.m. in person. You get to see all your smiling faces. And yeah, you got this. The review is opened up, so you can listen to that. You have the recordings are in there. The Kahoots are still in the exam. Yeah, so although the exam questions changed, the content's the same. So it just may be it's exact same information. Yeah, it's just the way that they're going to ask the questions. Yeah, I mean, that's the nature of it. So if I were a betting man, I'm guessing someone probably leaked 2 and 3 also. So those are probably going to wind up changing. But the content is all the same. I can assure you that hopefully you found out that by now, if you listen to the recordings, our lectures, the reviews, the Kahoots, I tend to go over everything. I try to give you everything to set you up for success. If you have any issues, you want tips for exams, I can give you that. I can upload something for that. But take a deep breath. You got it. You got this. So your ATI, I'll make sure everything that's set. And I'll put something in, I'll throw in exam taking tips. I'll put a folder in there today. So that's it. That's all I have for you. It's, let me stop recording.